Hey everybody, back for a second go around, going to respond to the questions that you all gave me on my forum post about the vestibular case history that I put up about a month ago now. Still coming straight after work to put in work, such as life. Now, let me start off with the first question. I'll just answer them in the order that I received them because being fast matters. So, for microsaccades, are there norms for this or is it clinician-based? So I think I'm going to answer this question in two ways. One, for our purposes, we typically just spot the microsaccades and then we just refer on from there. We don't necessarily have normative data as to what qualifies as a microsaccade or what qualifies as ocular flutter, if you want to be a little bit more specific about the type of microsaccades. But let me just redirect you real quickly to something that I found. So we have this article right here, Opsicolinus and Ocular Flutter Evaluation and Management by Grossman and Rucker. And right off the rip, it says ocular flutter and opsicolinus are abnormal spontaneous eye movements consisting of erratic bursts of high frequency, 10 to 25 hertz, high velocity back-to-back conjugate eye movements that oscillate about the midline of fixation. So not only does that describe the movement pattern that I saw, it also describes midline of fixation. That's why we found it during the gaze testing. Now, also, by definition, these movements have no intersaccadic interval, which means the saccades making up the burst of ocular flutter or opsicolinus occur back-to-back without stopping between sequential saccades. Opsicolinus and ocular flutter are often seen spontaneously in central gaze, but are also typically provoked in central gaze after shifts from an eccentric gaze position. So again, just more things that sort of double down on what I found and why I found it where I did. So if you're going to see these microsaccades, this ocular flutter, then you're likely to evoke it during gaze testing. And again, is talking about no intersaccadic interval. That just means that the movements are going to occur back to back to back to back. It's not going to have like this 2-second recharge time between eye shifts. So I hope that answers the question. Do I think his asymmetrical hearing loss exists independently from his balance issues, or are they tied together? At first, I was suspicious that they could have been tied together. You'd have vestibular migraine, Meniere's, these various conditions that can cause you to have an asymmetric hearing loss and also have, knockdown vestibular symptoms. But when I saw the issues on his left vestibular ocular pathway, I'm less sure about it. I can't say that it is for sure two independent things, but what I would say is I would have to delve into that further. I'm not really convinced in either way that they are not tied together or they are. Again, if I saw just a more classic presentation of, like a vestibular migraine or something like that, then I would be more inclined to say that, yeah, they are tied together. But it's just typically when you have these sorts of central issues, I'm a little bit slower to say that the hearing loss is 100% tied to that, especially because we didn't get tons and tons of hearing history from him, and we don't know what his audio exactly looks like to know how asymmetric that is and where it's asymmetric. So I would need more info. All right. So can I please explain what SVV is, because you'd like to learn more about it and how it specifically relates to this case? So here's how SVV works, at least in the rotary chair. So what we would do is on the rotary chair, you actually have like two handles with buttons. Think like, Atari 2600. And each button will allow you to tilt this line that we use with a laser that we project on the wall. The laser will be tilted. And then when you push the button, it will actually correct the laser line and make it go more vertical. I mean, depending on what button you push, you can push the wrong button. But depending on people's utricular function, their perception of what straight up and down will vary. So if someone has issues with either their utricle or their superior branch of the vestibular nerve, they will think that vertical, instead of being this, will be like that or that, depending on what side is affected. Typically, abnormal SVV skews will go to the lesion side. So if if you have a SEV that's tilted like that, that means that their left ear is busted. You go right here, their right ear is busted. Now, how does that relate to a case like this? Well, imagine how tough it would be to walk if one eye is telling you that vertical looks like this and the other eye is telling you that vertical looks like that. That is really, really difficult to try to see through and try to interpret. And you might be better with, your eyes shut, to be honest with you. But yeah, it's just with SEV, it's just a sense of utricular dysfunction or superior vestibular nerve branch dysfunction. And because he had the skewed perception of vertical on that left side, he was getting mismatched information, and that causes a lot of balance issues. If you are interested in the clinical norms, it's plus minus 2.5 degrees. So if you are more than 2.5 degrees off of vertical, that is considered an abnormal result. So next question was, do I know what happened to the patient after I made the referrals? Because you're curious if they found out what was exactly causing his symptoms. All right, this story isn't the happiest. So what happened was earlier that same day, he visited with occupational therapy. They guided him through some VBRT exercises, doing the, head shakes, eyes closed, head shakes, things like that to try to, get him to habituate to his condition. And he was doing okay, but he was struggling. And then they also gave him some tips on how to get some more functional mobility with a walking stick. So he's been using a walking stick to get around. Then on September 13th, there was a patient message sent to him through Epic that said, hey, we got your vestibular testing results. They think they found something with central pathology. So we want to give you a neurology referral and start that process. Unfortunately, he had a bunch of appointments booked, which from September the 15th to November the 10th were all canceled by the patient, except for one. The one booking that the patient had that was maintained was a consultation about a Mycobacterium haemophilum he had in his left laryngeal area. There was a large mass, and this mass was also causing vocal cord paresis. So he had this bacterial infection that built up into a mass, causing pressure on his vocal cords and making it hard for him to speak. He is currently on a regimen of moxifloxacin and azithromycin, which, given the suffix on those two, I'm suspicious of levels of aminoglycoside ototoxicity with those, but that's for another day. But yeah, I suspect that infection flared up and caused him to, need to take some time away from his regular appointments. Now, the bright side is he does have new appointments with occupational therapy and neurology for December the 20th and December the 22nd, respectively. So hopefully he just gets back up onto some regular treatment, and then we'll be able to just help his, balance issues from there. Now, next question was, in the beginning, were you always suspecting a central issue or peripheral? At the beginning, I didn't know exactly what to think. I thought, it could have been, peripheral, especially because, you had this difficulty walking and stuff like that. And I was thought, oh, maybe it's a utricular saccular thing. Maybe it's a hypofunction thing. And you talked about having other infections. I'm like, maybe like a neuronitis or something like that. But it was pretty quick. The gaze testing is the protocol that we start with. After calibration, it's gaze. And so once then I saw the ocular flutter, I was pretty sold on it being central, or at least partially central. I was really not suspicious of peripheral pathology once I saw that. And yeah, once the calorics came back normal, nah, bruh. This is definitely central. So when I saw the smooth pursuit results, did my mind go to central? Yeah, but I had a clue even before that. So the smooth pursuit results, the saccadic intrusions, my mind went to central pretty quickly. And, as much as sometimes you can get an abnormal, smooth pursuit, but have all the rest of the oculomotors normal, it's like between that and then the micropsychotic intrusions, I knew that we were not dealing with something that was just as simple as a little bit of an infection on the labyrinth. We knew that this was something that was bigger and something that was going to require a referral and something that was going to require therapy that was beyond us. So yeah, I kind of knew what my counseling was going to be about a quarter of the way through the testing. That being said, that answers all the questions that I got. And if I skipped over your question, that means you didn't write it to be stick out enough. So bold it, italicize it, underline it, change its color. See if I pick you next time. Do better.